Good morning. I'm Dr. Andrew LaBarbera, Chief Scientific Officer of the American Society for Reproductive Medicine. Welcome to the fifth presentation of the ASRM Grand Rounds webinar series in reproductive endocrinology and infertility. These twice-monthly webinars are designed to address topics in the ABOG Learning Guide in Reproductive Endocrinology and Infertility. We're very happy that you could join us today. Today's presentation will be given by Dr. Stephen R. Goldstein. Dr. Goldstein is the Director of Gynecologic Ultrasound at New York University's Langone Medical Center. His pioneering work in menopausal and perimenopausal ultrasound led him into design of uterine safety studies for several selective estrogen receptor modulators. The title of Dr. Goldstein's talk today is Early Pregnancy, Normal and Abnormal, How to Use Ultrasound and hCG Successfully. I will now turn the microphone over to Mr. Jeff Hayes, our education specialist, who will review the details of today's presentation and introduce Dr. Goldstein.
Thank you, Dr. LaBarbera. Hello to everyone. I'm Jeffrey Hayes, the ASRM education specialist and moderator for this webinar. Before beginning the webinar, I'd like to go over a few housekeeping items. One, to make sure we can cover all the content in the allotted time, everyone's line except the speakers will be muted. We will devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question in the chat window at any time. We will then read as many selected questions as possible to the presenter during the allotted questions and answer time. If for some reason you need to step away from the presentation, please sign out and then sign back in upon your return. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your CME credit. You must complete the post-test question successfully and complete the survey to receive credit and be able to print off your certificate. Our speaker today is Dr. Stephen R. Goldstein. We are very excited for his talk today, so I will now turn things over to Dr. Goldstein.
Thank you very much. Let's see if we can. All right, hopefully that's fine. Good morning, or wherever you are. I guess it's morning everywhere. So as you heard, what I want to talk about today, early pregnancy, normal and abnormal, how to use ultrasound and hCG successfully. This has been an interest of mine for several decades. My disclosures are I do a lot of things for a lot of people. None of them are really, I think, pertinent to today's talk, however. A lot of this is in the menopause space. At the conclusion of this presentation, you should be able to discuss when and why pregnancies fail and the prognostic significance of pregnancy failure, describe the biochemical detection of hCG and its relationship to pregnancy failure, list the characteristics of this new entity, PUL, pregnancies of unknown location, explain the relationship of ultrasound and biochemical testing in pregnancies of unknown location, and we'll touch a little bit on the use of methotrexate in the management of non-viable pregnancies. So when I was a resident, I was taught 25% of all pregnancies will bleed, and of those, 1/2 will proceed and 1/2 will fail. So go home, put your feet up, and you have a 50-50 chance. And interestingly enough, the powers of observation were pretty good. Those numbers hold up pretty well today, at least in natural pregnancies. But we can tell our patients a whole lot more than go home, put your feet up, and you have a 50-50 chance. In addition, we talk to our residents about the fact that any patient who is pregnant with any bleeding, and that's what really defines a threatened abortion, but any patient with any bleeding and a closed cervical os is a rule-out ectopic, is potentially an ectopic pregnancy until proven otherwise. So transvaginal ultrasound has changed things totally. Prior to the vaginal probe, ultrasound really was a tool of the obstetrician. Early equipment had barely enough resolution to do very crude things, anterior versus posterior placenta, vertex versus breech, measure of BPD, and people were often running in the obstetrical ultrasound business. And in fact, if you look at this early linear array real-time scan, this is a fetus at 4.3 centimeters or 11 weeks of gestation, and invariably somebody said, well, why didn't you put the cursor here instead of here? And I will admit there was some imagination in the early days of ultrasound. In my first book, I coined the phrase sonomicroscopy because I would put forth to you that the vaginal probe gives us a degree of image magnification that is as if we're doing ultrasound through a low-power microscope. we are seeing things with our ultrasound that you could not see if you could hold the structure in your hand at arm's length and squint it at it. So for instance, here is a 3-millimeter embryo at 45 days from the last menstrual period attached to its yolk sac, in which you can clearly see cardiac pulsations. And my point is, if you had a way to hold a 3-millimeter embryo in your hand at arm's length squinting at it, you would not appreciate cardiac pulsations contained within a 3-millimeter embryo. It is as if we're doing ultrasound through a low-power microscope. And that's one of the beauties of the technique, but also sometimes some of the foibles. We see every little ditzel the pelvis has to offer. So I say here early pregnancy, I think, has undergone a major change in the playing field. And I want to start with something as simplistic as what is a pregnancy? And I don't mean in the right to life sense, but certainly in the simplest of terms, it's when an egg meets a sperm. Now, that process of conception, implantation, development, and then birth is a long, long, arduous journey, or what the Greeks called an odyssey. Infertility, something many of you are very interested in, is the multitude of reasons why the process never initiates. What we're talking about today, pregnancy failure, is why a loss occurs after that conceptual event, but prior to the birth process. Very different from infertility. So when and why do pregnancies fail? And what is the prognostic significance of pregnancy failure? Now, interestingly enough, it takes some nerve to show you an article that is now almost 28 years old. And yet I would put forth to you that Wilcox's study is more relevant today than when he published it. So let me walk you through this. Wilcox took 221 women attempting to conceive, mostly nurses and nursing students. He got a daily urinary chorionic gonadotropin level by a very sensitive radioimmune assay. 22% of the pregnancies that were detected by this assay bled at or around the time of the expected menses. And he dubbed these chemical pregnancies. But of these, 35% were clinically pregnant the next cycle, 65% by the third cycle, 83% by the sixth cycle. This is an excellent prognostic sign. It proves they ovulate. It proves at least one tube is open. It proves their partner makes sperm. It proves they can capacitate their partner's sperm. And so the patient now who has a home pregnancy test that's positive on Sunday and bleeds like a menses on Tuesday feels she has suffered a miscarriage, and she mourns the loss, and she feels that she'll never have a baby, that there's something wrong. And yet, based on this, that chemical pregnancy, her prognosis in the next 1 to 6 months is infinitely better than her friend, sister, coworker, neighbor who wants to be pregnant but is simply getting her menses month after month after month. And so I say this is extremely important because now our patients can diagnose a pregnancy event with an over-the-counter home test at the time of the missed menses. And that's at a level of about 30 to 50 milli-international units per mil of hCG, human chorionic gonadotropin. Based on Wilcox, 22% of these patients who have a positive home test can be expected to fail. This is also the positive home test caused an epidemic of these pregnancies of unknown location, these PULs, and we'll talk more about that later. So if previously a chemical pregnancy was a loss that occurred prior to clinical recognition, and now our patients are clinically recognizing a pregnancy event at the time of the missed menses, I'd like to change the definition of a chemical pregnancy to a loss that occurs prior to the onset of the embryonic period. Now, why do we lose chemical pregnancies? Well, we can only speculate. We don't have tissue to study. Are there hormonal reasons, inadequate luteal phase? Are there chromosomal reasons? If so, what's the type and incidence compared to the embryonic losses that I'll talk about in a moment? Is there defective implantation? In terms of embryonic losses, this article, now almost 25 years old by Ono, is still the largest and the best study. What did Ono do? Took 144 spontaneous abortions, did direct preps of the chorionic villi. Whoa, sorry about that. Direct preps of the chorionic villi. 70% had abnormal chromosomes, of which about 2/3 are autosomal trisomies, 9% polyploidy, 7% monosomy X, and 6% structural rearrangements. So how do you get an abnormal chromosome in your conceptus? We said it accounts for about 70% of embryonic pregnancy failure. Errors of gonatogenesis during meiosis are what give us the trisomies. Errors of fertilization, well, dispermy gives us triploidy, and errors of the first division of the zygote give us tetraploidy or mosaicism. None of these would be expected to be repetitive except in the very rare instance of a balanced translocation or inversion in one of the parents. 30% of losses that are non-chromosomal, well, this is where uterine abnormalities come into place, uterine septa, myomas. Actually, incompetent cervix doesn't really belong here. That's probably a loss into the second trimester. Luteal phase defects. Are there autoimmune factors like antiphospholipid syndrome? I think the thrombophilias are more of an issue later in pregnancy with growth restriction and preeclampsia. Infectious agents, mainly with the T strain mycoplasmas, maternal alcohol, maternal smoking. And are there molecular genetic abnormalities that may have normal karyotypes? So I got very interested in this topic, once again, almost 20 years ago. And as a little aside, there's a thing called the New York Obstetrical Society, a very posh group. You used to have to, everybody wore a tuxedo, then just the officers wore a tuxedo, then just the president wore a tuxedo. Now everybody wears what they want. But I was at the New York Obstetrical Society meeting at the Yale Club one day, and this guy, Tom Karenyi, very venerable clinician on the east side of Manhattan, his partner, Jonathan Scher, and Karenyi said to me, so what's new? And I said, wow, I've karyotyped 2 failed pregnancies prospectively when I did a D&C for a failed pregnancy. One was trisomy 6 and one was trisomy 22. He said, we've been doing that for 4 years. I said, you're kidding. You should write that up. Well, he was a busy clinician. He wasn't interested really in writing anything up. But he was good friends with the Hungarian financier, George Soros. And Soros used to pay for a fellow from Hungary to come after residency to spend a year at Mount Sinai with Karenyi and Scher. So that year, Csaba Pop was the Hungarian fellow. So Csaba Pop and I went through all these cases from Karenyi and Scher's office. So stay with me because this seems paradoxical. If we karyotype a failed pregnancy that produces abnormal chromosomes, that's a good thing. It gives the parents a definitive diagnosis, and it allows for no further workup at that time because it should not be repetitive. However, if you karyotype a failed pregnancy and you get normal chromosomes, well, then you might want to do a workup for that 30% of things that might be expected to be repetitive. So we don't have to talk about, is habitual miscarriage 3 losses, 2 losses? If you have the opportunity, you can karyotype a first pregnancy and triage people to either no further workup or maybe work them up at that point. There were 102 patients who had sonographic evidence of early pregnancy failure. They had an elective D&C in the office. And what they did was they sent the products of conception to the same lab they used to send amniocentesis specimens to for karyotyping. They had 58 normal karyotypes, of which 52 were 46XX, 6 were 46XY. Now, am I going to try to convince you that the ratio of female to male in failed pregnancies is almost 9-to-1? No. What's going on here? Tremendous amount of maternal contamination when you simply submit products of conception for karyotyping. However, the abnormals, which would be valid, ours were very similar to Ono. Ono had 2/3 trisomies. We had 75% trisomies. We had the triploidy, the tetraploidy, the monosomy X, and the unusual isochromosome or unbalanced complement. We found that an abnormal yolk sac, in this case greater than 6 millimeters, with or without abnormal morphology, was a nonspecific sign of a failed pregnancy, whether the karyotype was normal or not. And here's an example of a hydropic enlarged yolk sac measuring almost 9 millimeters and an 11 millimeter embryo with no cardiac activity. There were some trends. Trisomy 22, the mosaics, monosomy X, tend to develop pretty far. Embryos 11, 11, 18, 9, 24, 14 millimeters with cardiac activity before they demised. Whereas trisomy 16, the multiple trisomies, the isolated variants, virtually never developed embryonic structures or cardiac activity. So what do we conclude? Well, if you get good at separating the villi with its attached chorion from mom's decidua, you can reduce the incidence of maternal contamination, the 46XX, which results from merely submitting products of conception for karyotyping. So what exactly is a PUL, a pregnancy of unknown location? PULs are the result of the widening gap between biochemical detection, we said with the home pregnancy test, at about 30 to 50 MIUs per mil of hCG, and our sonographic confirmation. And I say here, what is the appropriate discriminatory zone for hCG? hCG is produced by trophoblastic tissue. It's detectable about 8 days post-conception. Our residents here at NYU still erroneously refer to this as the beta subunit or simply the beta. They have a beta book for the roulette ectopics at Bellevue. This is to distinguish it originally from the alpha subunit that's shared with TSH and other molecules. However, most tests that you're employing are measuring the intact hCG molecule. We said that over-the-counter home tests turned positive at about 30 milli-international units per mil at the time of the Miss Menses. hCG normally rises a minimum of 53 to 66% every 48 hours. Now, I'll go into that. It usually will double every 48 hours. The problem is 15 to 20% of ectopic pregnancies will follow absolutely normal doubling times of hCG, and those are the occasional ectopics that end up with a good embryo with or without a heartbeat. Pregnancy is seen on transvaginal ultrasound by an hCG greater than about 1,000 milli-international units, the discriminatory zone, and this has come into question, and we're going to explore all of this. So what should the rate of rise of hCG be in an ultimately viable pregnancy? Well, the original granddaddy study that most people used for over 20 years was done by Nick Kadar and Roberto Romero at Yale in 1981. It's interesting to go back and look at a study that's 34 years old. But they said the minimum rate of rise was 66% in 48 hours. You know, this was based on 20 patients. It was done with transabdominal ultrasound, and it was only the 85% confidence limit, but it was the letter of the law for more than 20 years. Many of you have heard of this 53% number, minimum rate of rise in 48 hours. Where does that come from? Let's take a closer look at that number. Kurt Barnhart at UPenn published based on 287 patients that had either pain or bleeding, whose initial ultrasound was non-diagnostic, who ultimately had viable intrauterine gestations. The average increase in 48 hours, 2.24-fold. That's more than double. The minimum increase in 48 hours, 1.53-fold, that's where the 53% increase comes from, 99% confidence interval. In fact, the greatest increase at 48 hours was more than triple. But remember, his were symptomatic patients that ultimately proved to be normal. This may or may not be applicable to our asymptomatic patients who often present quite early. And in the private world, you know, nobody does one home test. My patients do 4 home tests and usually call in there about an hour late for their menses, although I travel enough so that I can often put them off for at least a week. In addition, a subnormal rate of rise does not diagnose an ectopic pregnancy. It can diagnose a non-normal gestation, but that says absolutely nothing about location. So now we need to get into this discriminatory versus threshold level. Threshold level is the earliest you sometimes see something. So for instance, I have seen a gestational sac when the hCG was 691, but that's not the issue. The issue is at what level of hCG, if I do not see a sac, am I dealing with a definitively non-viable situation? And that's what defines discriminatory level. Carol Benson and Peter Duboulay, a husband and wife team at Brigham and Women's, good friends of mine, radiologists, published in the Journal of Ultrasound and Medicine a 10-year review of scans at Brigham and Women's. They said they had 9 scans where the hCG was greater than 2,000, that initially only had a fluid collection on ultrasound, but were ultimately deemed to be viable. 5 resulted in a live singleton birth, 1 a twin birth, and the other 3 miscarried. So they concluded, quote, the hCG discriminatory level should not be used to determine the management of a hemodynamically stable patient with suspected ectopic if sonography demonstrates no findings of an intrauterine gestation or an ectopic. Well, I'm not sure that I agree totally with their conclusion. You know, I ran the Residence Journal Club here at NYU for 20 years, and I try to teach people to read the literature with a discerning eye. In their article, there was no mention of what their denominator was. In other words, how many women were scanned in that 10-year period to come up with 9 cases? Nor did they mention how many ectopics were in fact picked up and treated, whose initial scan was no intrauterine gestation, but had an hCG greater than 2,000. And as radiologists, I think they underestimate the potential morbidity and even mortality associated with ruptured ectopic. It is still the leading cause of death, maternal mortality, in the first trimester. So I would agree there are many potential shortcomings from a single hCG determination and its corresponding ultrasound, but we pointed this out 27 years ago. In fact, it's interesting to go back and read an article you wrote 27 years ago. This was called Very Early Pregnancy Detection with Endovaginal Ultrasound. We had 235 patients. What do we conclude? That all normal gestations had a sac visualized when the sac was greater than 4 millimeters and when the hCG was greater than 1,025. If the uterus was normal and had homogeneous echo pattern. 27 years ago, we had 3 cases where the hCG was greater than that. In fact, one had 5,544 with coexisting fibroids in which we did not see a gestational sac. So it not only needs to be a normal sac, it needs to be a normal uterus. So what are some of the potential problems with the discriminatory zone? What are some of the situations where your hCG might be greater than 1,000 or even 2,000 and an IUG not seen but still be normal? And this is going to depend on issues like the equipment you use, the frequency. I hope you all know higher frequency, better resolution, less penetration. The degree of magnification. Are there coexisting myomas? Is mom markedly obese? You know, we all know about the panniculus and it attenuates sound, but the entire peritoneal cavity is surrounded by fat. And so even transvaginal ultrasound in a markedly obese patient is less reliable. The axial uterus. People used to think the retroverted uterus was a problem. The closer to a right angle the beam of sound is to the structure you're looking at, the better you're going to see. And most dangerous, multiple gestations. So what do? If the hCG is less than a discriminatory level, we should repeat it when we expect it to surpass that level, and I still will use 1,000 if it's a normal uterus. But the endometrium on ultrasound, while lacking a gestational sac, should at least have an appearance compatible with an early ongoing normal pregnancy. It ought to be lush and homogeneous and that decidualized secretory appearance. So for instance, this is an axial uterus. See how the endometrium is in the same plane as, here's the footprint of the sound. If the endometrium were here, that's an anteverted uterus. If the endometrium were here in a retroverted uterus, you would see better. But in this axial uterus, you don't see a gestational sac. Well, I'll get an hCG and I'll tell this patient, I expect her hCG to be greater than 50, less than 1,000, in which case I would repeat it at appropriate intervals until I can see something on ultrasound. This woman, her endometrial cavity is distended with blood, clot, and fibrin. This is not going to be a normal intrauterine gestation in 48 hours. This may well be a normal intrauterine gestation in 48 hours. What about the thickness of the endometrial echo? And if you use the word endometrial stripe, please lose the word stripe. It is not a medical term. ACOG likes to use endometrial thickness. I talk about endometrial echoes because it is ultrasound. But Sieber published in the Journal of Reproductive Medicine on 576 patients. That's a lot of patients coming to an emergency room who did not have a definitive intrauterine pregnancy on their ultrasound. They measured the endometrial thickness and then reported the ultimate outcome. The average thickness in ectopics 9.6 plus or minus 5. Average thickness in the viables, 12.1 plus or minus 6. Average thickness in what turned out to be spontaneous abortions, 10.2 plus or minus 6. What's the take-home message? In patients with bleeding, endometrial thickness is not a reliable predictor of outcome. But you're good at math, and they didn't say this in the paper, but if the viables were 12.1 plus or minus 6, one of the take-home messages is that an endometrium less than 6 is rarely going to be compatible with an ongoing viable intrauterine gestation. So what constitutes a definitive intrauterine pregnancy? And I say the corollary here is the best way to exclude ectopic is to prove an intrauterine. Unless you're doing assisted reproductive technologies, heterotopic pregnancy, for all practical purposes, doesn't enter into the discussion. So prove an intrauterine, you exclude ectopic. So let's talk about this. Gestational sac, something we use all the time, not an anatomic term. Nowhere in the embryology books they talk about a gestational sac. This was a sonographic invention by early sonologists and sonographers to distinguish the true intrauterine pregnancy from the so-called pseudosac of ectopic pregnancy. It's characterized by an echogenic rind around a sonolucent center. And we recognize it, as you recognize anything, by what it looks like, by its appearance, not by where it's located. So here's a cartoon. The chorionic membrane surrounds a fluid-filled chorionic cavity. Projecting from the chorionic membrane are these primary trophoblastic villi. Well, here's a conceptus at 5.5 weeks LMP. The chorionic membrane looks a lot like a soft contact lens. It's a little cloudy. These primary villi, some of them are going to bud and branch and proliferate into secondary and tertiary villi and become known as chorion frondosum, forerunner of placenta. Others of these villi will regress and become known as chorion lave. But initially, these primary villi invade mom's decidua, and they produce this trophoblastic decidual reaction around the sonolucent center within the decidualized endometrium within the uterus. And this is what constitutes a gestational sac. Now, we talk about it being eccentric. Well, sure, here's the midline echo. Here's a tiny sac burrowing in anteriorly. Here's the midline echo, and here's a sac burrowing in posteriorly. When should you see a sac? Well, usually by 5 weeks LMP, 3 weeks post-conception, but we know that dates can be notoriously unreliable, and this is where the concept of a threshold level and a discriminatory level come into play. The yolk sac was really not appreciated in the early days of transabdominal ultrasound. It's the first structure we see within the gestational sac. It should be round, have a bright rim, less than 6 millimeters. And when it's enlarged, which I believe is a hydropic sign, solid or duplicated, these are very poor prognostic signs. So here's the yolk sac contained within the gestational sac. Here's another yolk sac. You can see the embryo starting to develop along its edge. Here's another yolk sac with an embryonic structure, and this is an enlarged hydropic yolk sac in a case of pregnancy failure. Well, this is going to be a little harder to convince you of, but I would like to get rid of the concept of first trimester. Where does it come from? Why do we divide pregnancy into trimesters? I mean, I think it traces its origins as the point when the uterus goes from a pelvic to an abdominal organ. Pregnancy through the first 12 weeks from the last menstrual period is the first trimester. I put forth to you it's an arbitrary time divider that does not reflect naturally occurring events, either in terms of anatomy, development, or even loss rates. Instead, we'd be better off of thinking early pregnancy has an embryonic period, which is a 5-week window from 35 days LMP to 70 days LMP. It is a time of organogenesis, and thus concerns about teratogens are real. And even the word embryo comes from the Greek for metamorphosis, and we go through a tadpole-like stage complete with a tail. The fetal period begins at 70 days LMP, not 12 weeks, that's 10 weeks. It is a time of growth and differentiation, not organ system development. And even the word fetus comes from the Latin for offspring, or having a human-like appearance. And so here's a 3 millimeter embryo at 45 days. Here's a 5 millimeter embryo at 47 days from the last menstrual period. Here's a 7 millimeter embryo at 49 days. Here's an 11 millimeter embryo at 53 days. Here's a 13-millimeter embryo, C-shaped tadpole-like structure at 55 days LMP, and at 22 days LMP, 22 millimeters, which is now 9 weeks and 1 day. For the first time, we really have a crown to rump length. There really hasn't been a crown yet. Here's a 17-millimeter embryo, crown to rump length, rhomencephalon, and a 35-millimeter fetus at 10 weeks of gestation. Even the most inexperienced observer, yes, not the student, the patient and her husband can say, oh, look, there's the baby, because it has a human-like appearance. So what are some of the keys to successful use of early pregnancy ultrasound? When should you see a yolk sac? Well, threshold level, here's a yolk sac in a gestational sac that only measured 4.7 millimeters. This is probably transducer dependent. Rollins published on the fact with the newer 5 to 9 megahertz transducers that they always saw a yolk sac by mean sac diameter of 5. But here's a 28-millimeter sac in which there's nothing inside. No matter how much mom wants a baby, there is no point in doing another ultrasound. There is no point in doing another hCG. This woman has a failed pregnancy. Here's another failed pregnancy with a hydropic yolk sac. Here's a solid yolk sac in a failed pregnancy. Why is this important? Well, does a yolk sac need to be present to make a definitive diagnosis of an intrauterine? The emergency room people have started doing a lot of ultrasound, and they feel that unless they see a yolk sac, they're uncomfortable making a diagnosis of a definitive intrauterine. I don't agree. What about cardiac activity? Well, realize the endothelial heart tube folds on itself and begins to beat by 21 days post-conception. It's the first organ system to form. It's there and beating before our ability to actually see it. And so the question is not how early can I see it? The question is at what point, if I don't see it, should I be calling a pregnancy definitively non-viable? Previously, probably the best American study was by ABAD in the Journal of Reproductive Medicine, about 180 gestations, 8 megahertz transducer. Basically, anytime you got greater than a 3-millimeter embryo, they were always able to see cardiac activity. But more recently, some new data and guidelines have come out of Britain, where they have these specialized early pregnancy units. And they revised their green top guidelines from the Royal College of OBGYN. This is like ACOG's practice bulletins. But they raised the threshold for diagnosing miscarriage, and I have a problem with that. To me, miscarriage is the spontaneous passage of a failed pregnancy. It should be threshold for diagnosing failed pregnancy, mean sac diameter greater than 25 with no yolk sac, and a crown rump length greater than 7 with no cardiac activity. And I thought about this a lot, because most clinical trials, especially randomized clinical trials, are well designed, tightly controlled, performed by better trained clinicians, often with state-of-the-art equipment. This is versus practice in the field by well-meaning healthcare providers, often without the same level of quality control, same level of equipment or expertise, but still expected to duplicate the data from the trials that were used to create the guidelines. So understand there's a huge difference between calling a definitive pregnancy failed and getting follow-up scans if there's still any chance of it being an ectopic. Clearly, no one wants even a single wanted pregnancy to be interrupted because of overzealous diagnosis of pregnancy failure. So it says here, give early pregnancy the benefit of the doubt. Once ectopic pregnancy has been excluded, let me say that again, once you've excluded ectopic, follow-up scan depends on the fact that the gestational sac grows about 1 millimeter a day, the embryo grows about 1 millimeter a day. You have a 3-millimeter embryo, you don't see a heartbeat, bring her back in 4 or 5 days, ought to be an 8-millimeter embryo, and she should have cardiac activity. I wrote that slide 27 years ago, and I believe it is still the cornerstone of clinical management. There was a consensus panel that I was fortunate enough to be included with, which published in the New England Journal of Medicine. It was an international panel, and they now have the threshold crown rump length greater than or equal to 7 with no cardiac activity, mean sac diameter greater than 25 with no embryo. In addition, if you have no embryo with cardiac activity 2 weeks after a scan that had a sac, but there was no yolk sac, or 11 days after a scan that had a sac with a yolk sac, but now there's no embryo, these are criteria for failed pregnancy. Suspicious for, but not diagnostic of a failed pregnancy, well, an absence of an embryo more than or equal to 6 weeks past a firm LMP, an empty amnion, in other words, an amnion adjacent to a yolk sac with no embryo. They're saying a yolk sac they use greater than or equal to 7 millimeters, and a small gestational sac relative to embryonic size. In other words, less than a 5 millimeter difference between mean sac diameter and crown rump length. These are things that are concerning but not diagnostic of a failed pregnancy. So let's get back to this PUL, pregnancy of unknown location. I say to you, the patient who presents to us with biochemical evidence of a pregnancy event but is now staining can fall into one of 3 buckets. She can have a definitive intrauterine pregnancy. Okay, you put the probe in and you see a gestational sac burrowing in posteriorly, you've made the diagnosis. She could have a definitive intrauterine that isn't normal. She has a big old empty sac and she's a case of failed pregnancy. She could be a definitive ectopic. Here's a gestational sac with a yolk sac and an embryo. The only problem is this is not in the uterus, so this is definitive. Or here's a more modern clip. There's a ectopic right down here. You'll see as the clip goes through again. You can see the vascularity around the outside. It's right here, and here's the ovary on the right side. Or she can be everything else in the middle. She's not a definitive intrauterine, she's not a definitive ectopic, then she's a pregnancy of unknown location. And this is where the concept of quantitative hCG and discriminatory zone come into play. So here's a lady, she had a positive home test, she started staining, she comes in, she's got an axial uterus, she's got a nice homogeneous endometrium. You listen to Goldstein's lecture, you get an hCG, her hCG, you say you'd like it to be between 50 and 1,000. And it says everything else in the middle category that's on the rise because of the widening gap between biochemical detection and the ability to see a sac on transvaginal ultrasound. So if you've got a positive pregnancy test but no intrauterine on ultrasound, what's the differential? This could be an early intrauterine, just too early to see. You could have a failed intrauterine that's collapsed but you can't detect sonographically, or you could have an ectopic. And if you have an ectopic, it may or may not be thriving. So what do you do? Well, in the original description of using methotrexate, they talked about doing a D&C and looking for chorionic villi. If you found chorionic villi, you proved an intrauterine pregnancy. If you had decidua only, your index of suspicion for ectopic was much higher. But I would say be careful. The use of methotrexate after a single seemingly elevated hCG with no intrauterine has become a common source of lawsuits if it turns out to be an intrauterine that was either unappreciated or it was a poorly performed scan, multiple gestation, coexisting fibroids, axial uterus, etc., etc. Methotrexate, oh, sorry about that. Methotrexate is a folic acid antagonist. It inhibits DNA synthesis and cell reproduction, mainly in very actively proliferating tissues, like malignancy, trophoblast, or fetal cells. It's been widely used in cancer, psoriasis, rheumatoid arthritis, and more recently, ectopic pregnancy. And I say here, even ACOG got it wrong for 10 years. The practice bulletin in 1998 used to say, and maybe some of you have heard this bantered around, to use methotrexate, you want a mass less than 3.5 centimeters, no cardiac activity, you want an hCG that doesn't exceed 6,000 to 15,000. Well, think about it. How does methotrexate work? It works on the trophoblast. So the quality and health of the trophoblastic tissue will be the most important determinant of success, not the size of the mass on ultrasound or the absolute level of hCG. For instance, let's say you've got a mass that's more than 3.5 centimeters, but it's mostly blood, clot, fibrin, hematosalpinx. Well, it's going to do better than a mass of 2 centimeters that's a beautiful looking choriodecidual like the ones I showed you. Or let's say woman A has an hCG of 2,000, but 48 hours ago it was 1,800. It's only gone up 10%. Woman B has an hCG of 1,500, but 48 hours ago it was 750. It's doubled. Well, the woman at 1,500 that's doubled will not do as well with methotrexate because she has a very healthy, intact choriodecidual unit. And so in 2008, ACOG changed the bulletin. I was on the GYN practice committee. I got them gadflied No longer gave a level of hCG nor size of the mass as a criteria. Tells us to check serum creatinine, LFTs, rule out blood dyscrasias before you give it. We expect a 15% drop in hCG from day 4 to day 7. If not, we give more methotrexate. But interesting, it's important to remember, not unusual to experience abdominal pain 2 to 3 days after administration, presumably from the cytotoxic effect causing tubal abortion. The whole reason you use methotrexate was to avoid going to the OR, so don't rush to the OR. And finally, treatment of non-normal gestations of unknown location. Is a D&C always necessary? Let me give you a couple of examples. A couple of cases. 38 days from the last menstrual period, staining, positive home test. You do an ultrasound, you've got that nice homogeneous decidualized endometrium, but no intruder on gestation. So you paid attention, you get an hCG, rooting for greater than 50, less than 1,000. Comes back 740. So far, so good. 48 hours later, hCG is 210. Well, what's your diagnosis? This is a failed pregnancy. You've never established its location, but you will treat her expectantly with that degree of drop. But woman B, same thing, 38 days, LMP, staining, positive home test, homogeneous endometrium, no intrauterine, hCG 740. 48 hours later, hCG is 815. Well, that's a 10% increase. Now, invariably, somebody says to me, yeah, but the first one I got in the lab, and they're closed on the weekend. I had to send her to the hospital. She really wants to be pregnant. I say, fine, get one more. You get one more. Now it's 906. It's another 10% increase. What's your diagnosis? This is a non-normal pregnancy. You've never determined its location, but hCG is rising, means there's some viable trophoblast. Do you give her D&C, look for villi, or do you just give her a single shot of methotrexate? Because with that level of rise, methotrexate will work every time. But realize if you do that, you're going to be treating a sizable number of failed intrauterines with a shot of methotrexate. And finally, as long as we're talking about pregnancies and their location, my final pearl, and I alluded to this, what we recognize in ultrasound depends on how normal something appears, not where it's located. So here's a beautiful yolk sac with an embryo in the uterus. Here's a beautiful yolk sac with an embryo in the adnexa. Recognize it by its appearance. Here's a 22 millimeter crown rump length in the uterus. And don't make the mistake the fellow at Bellevue almost made. Rule out ectopic, puts the probe in, saw this, was going to send her out. 25 millimeter crown rump length. Only problem is this is not in the uterus. He had never seen this degree of development in an extrauterine pregnancy. And I apologize, this is a technology called static arm scanner. And the reason I still showed this picture of an ultrasound, okay, is because I can't find a pathology that looks like this. Rarely do we do it with hysterectomy with the fetus cornual pregnancy in situ. And many people would miss this ectopic because it was a mishmash of blood, clot, and fibrin. So in summary, we talked about what constitutes a pregnancy, what early pregnancy looks like and why. Pregnancy failure, how to recognize it, why it happens. Biochemical detection at 30 to 50. Transvaginal ultrasound in a normal uterus at about 1,000. And how these PULs are an epidemic because of the home pregnancy test and the widening gap between biochemical detection and transvaginal ultrasound confirmation. And finally, we touched on some management issues regarding D&C versus empiric methotrexate and realized that there's no data to support this. I thank you very much for your attention.
Thank you so much, Dr. Goldstein, and we'll hold here for just a moment to ask, of course, everyone who's been in attendance today. If you have a question you'd like to ask, please go ahead and type it in the chat window. Dr. LaBarbera, are there any questions? Or
we don't have any questions at this point. Well, since we don't have any questions, Dr. Goldstein, I want to thank you very much for a very lucid presentation of a topic that is of interest and concern to all practitioners. Thank you very much. I'll now turn it over to Jeff.
Oh, Thank you so much, Dr. LaBarbera. And thank you, everyone, for attending today's webinar. This is the 5th in a Grand Round series of webinars the ASRM is presenting. Our next webinar is Thursday, December the 3rd at 6 o'clock p.m. Eastern with Dr. Sarah Berga, who will present on the topic of neuroendocrine function and disease states. Look for an email from ASRM with registration details soon. Also, this and all of the ASRM Grand Rounds webinars are posted for rewatching after the initial broadcast. So please visit the ASRM website and look over our Grand Rounds webpage for further information. Thank you to everyone. Thank you especially to our presenter, Dr. Goldstein. This webinar is now ended.